So why don't we go ahead and get started? I know that I expect some additional reporters to trickle in, but let's go ahead and get started. We want to be respectful of your time.
Yep. Okay. Good morning. I'm Alan Weil, Editor-in-Chief of Health Affairs. We're really thrilled to be doing this in partnership with the Alliance for Health Reform, and you'll hear more about that in a moment from Marilyn. I can't help but hold up today's issue of Health Affairs under embargo until 4 o'clock, but we have a few copies here, so if you ask good questions, you can get a prize. The topic for this morning really requires no introduction, but I'll do a very brief one nonetheless, which is we are entering the third cycle of open enrollment under the Affordable Care Act. It is hard to believe that the first cycle was completely dominated by challenges with the federal exchange. In the second cycle, we had a combination of a much better functioning system, but a little more attention to what was happening at some of the state exchanges and the variation in their performance. We, of course, had King v. Burwell placing a cloud over the question of whether or not state exchanges could, the federal states without their own exchanges could get subsidies. But as we move in now, it's really a great opportunity to talk about where we've been and some of the more mature issues for states that have been doing this for a while, really talking about plan selection and consumer choice and not just technology, although there's a component of that as well. But it's a good time to have this conversation, and so we're thrilled to host it for you. Marilyn.
Great, thank you. So before we get started, I just want to let you all know that, as Alan mentioned, this is a partnership with Health Affairs, the Alliance for Health Reform, and the JKTG Foundation. And this is the first in a series of 6 briefings that we're going to be putting on for reporters right here in the Press Club. And so stay tuned, maybe one every 6 to 8 weeks. So we'd love to hear from you on the evaluation sheet today about what topics and speakers you'd like to hear from, because we are very happy to comply. So, as Alan mentioned, we are going to be talking about Open Enrollment 3 today, and we are very fortunate to have with us 2 exchange executives. To my right, we have Peter Van Loon, and he is the Director of Exchange Solutions for the Connecticut Exchange. And we have Mila Kofman, who is Executive Director of the DC Health Benefit Exchange Authority. And then all the way to my left, we have Joel Ario, who's a Managing Director at Manatt Health Solutions. And Joel also was the first director at HHS's Office of Health Insurance Exchanges. So we've got a wealth of knowledge here, and we will, each of them will give us a some short introductory remarks, and then we'll open it to Q&A. So, so why don't we get started? Joel, did we say you were going to start?
I didn't know how we did it, but I'm happy to start if you want me to.
Take it away.
Okay. So I'll try to put a little context, because I know, picking up on what Alan said about Mila and Peter being able to kind of go deeper, look at some of the refinements, and I think particularly they're going to talk about some of the plan selection issues that become more and more important, I think, as we move forward, consumer experience kind of questions. But just to give a broader context, I mean, affordability is still job number 1 for the exchanges. Prices are a whole lot more stable in this market today than they've ever been in the individual market. I've been at this business for 20 years, and it used to be commonplace to see 20, 30% rate increases. Now they get a lot of attention. There are some of those, but they're not commonplace. They're more unusual. We have many of the markets kind of stabilizing. California would be an example. I always look at California as kind of a bellwether where things may be headed, as it's a more mature kind of exchange environment out there, and their rates are pretty stable, 4% increases in general. There are some counterexamples out there this year, so prices aren't completely stable yet, but they are moving towards stabilization. The decision on risk corridors last week notwithstanding. So that's kind of point number 1. Point number 2 then is, how do you keep those prices affordable? And from the beginning, beginning, although some people are still in denial about this, from the beginning, the two main strategies under the ACA for keeping prices down are manage your networks. Some people call them narrow networks, other people call them selected networks, but they're managed networks. Look carefully at how you set up your networks and try to leverage prices best you can with the provider community and how you do that. That's always been job, the one area of competition that's most left open under the ACA. And the second one that's built right into the law is higher cost sharing than we've had, at least on the employer side. This is lower cost sharing, I'll hasten to add, than what we saw, as Mila well knows from our days as insurance commissioners together. It's less cost sharing than there traditionally was in the individual market, but it is more cost sharing than there was traditionally in the employer-based market. So it's still, and we've got a lot of issues to work through, like specialty drugs. I have a boy that's on specialty drugs. I know the issue very well. So there are issues there, but higher cost sharing is here to stay. I will submit to you. We're not going to, as I like to say, Congress is debating whether to add a copper plan, not whether to get rid of bronze plans. So we're going to have the higher cost sharing and the networks, managed networks, and those issues then are going to present challenges, which gets me to the third point, which is in order for the system then to work well, consumers are going to have to be more aware of what they're buying than they've been in the past. And I think we've seen an amazing ramp up of consumer understanding, although we still have a long way to go. And there are basically two strategies there. Some states, and Peter Lee in California is the strongest proponent of this, go towards standardization. We need to have fewer kind of complicated choices for consumers. Clearly some choice, but more standardization than the ACA allows. The other strategy is, let 1,000 flowers bloom out there, but then have really strong search tools available to consumers. And I think there's a good argument for strategy number two as ultimately the more important of the two strategies, because even when you standardize, you're still giving people, if you get more than two or three choices, it's pretty hard to figure out some of these things without a good search tool. So I think the search tools are important, and we get into this in questions, but RWJ did a competition, Robert Wood Johnson, where they picked the three that they thought were leading today. One of them is Checkbook, which Mila has smartly hired in D.C. The second was an outfit called Stride Health out of California that's a web broker that's, I think, definitely worth looking at. You can get to a decision through their tool, in a couple minutes, generally, geared towards young millennials. And the third is Clear Health Analytics, which Enroll America has hired now to help do a decision tool for the federal exchanges. So I think those tools are very important, and I think that a lot of this is what Mila and Peter are going to take up in their presentation. So I'll stop with that. Uncharacteristically quick for me, Alan, but I'll stop. And we'll take the next speaker.
Thank you so much, and I appreciate the endorsement of option two, where you have lots of different plans and innovation, but it's really critical to have good consumer support tools. So as we get ready for Open Enrollment 3, our major focus is, in fact, on consumer decision support tools. In 2016, we will have 136 different small group plans and 26 different individual plans. 2 of them are catastrophic. And when we first launched, we heard criticism. Are you going to have enough products? Now the criticism is overwhelming. To no surprise, it's overwhelming for me as a shopper myself. So this year, we focused on figuring out what we can do better for our customers. So we are working with Consumer Checkbook. And we chose them because they have several decades worth of experience with federal agencies, and they have a lot of expertise on what really matters. You don't have to ask a consumer for 20 different, answers to 20 different questions. You don't need that much. You need a few key data points to be able to help the consumer make a better decision, more informed decision. So Checkbook has developed DC Health Link Plan Match, and we launched a beta version of this. I've lost time. I think it's been 2 weeks now. as I get closer to open enrollment, I kind of lose track of what week we're in and what month we're in. So we launched that as a beta. And on the individual side, we will launch a beta for small groups sometime next year. And it's really simple. You put in your age. There's no geographic rating here, so it's just one area. And you put in a self-assessment of your health. And if you're an economist, you know that people are really good predictors of what their claims will be. There's a lot of evidence out there, as I'm sure folks around the table will share, that you can pretty much predict what your needs will be in the following year. And then you can, if you plan to have surgery, knee surgery, or hip replacement, there are various conditions for next year's medical needs you can put in if you want to, for yourself and your family if you're looking for coverage for family members. And then you'll get essentially information about what your total out-of-pocket expenses may be the following year. That includes your premiums and your deductible and your co-insurance and co-pays. And you also get what a good year looks like and what a bad year may look like. And it's really incredible to see the use of this tool, because even my assumptions about which health plan might be best for me are sometimes wrong, and sometimes I'm better off purchasing a gold plan than a bronze plan, depending on my circumstance. So we're really excited about that. Earlier this year, we launched a doctor directory, and that was really important for us. We launched a Spanish beta version in August and a final English version in August. The beta version in English was launched earlier in the spring. What we saw in the first couple of years is this, what I describe bait and switch. A customer goes onto a health plan's website, looks for a doctor. Doctor is listed in network, and what do you know? After you sign up, the doctor is not in the network. And maybe the doctor moved away or retired. And then customers who need particular access to certain physicians are disappointed. And they made a decision based on bad information. So we launched a single an all health plan doctor directory. So you go onto our website and you can put in physician's name and get all the health plans the physician is participating in. And then if there's bad information, there's a loop back to the health plans to give them information that is listed incorrectly on their own websites. So we're really excited about that decision support tool. The third initiative that we're undertaking is making the regular search engine online more user-friendly. So if you don't want to use consumer checkbook tool, you will still have access to more advanced search tools to help you make better decisions. In addition to all of that, we are thinking very hard about what we can do to reach the remaining uninsured. And the district has a very long history of having very low rates of uninsured. So we not only have the hard to reach, but we have what my communications person calls a die hard to reach. The census report, the recent census report indicated that we've cut the uninsured rate in the district by 20%. So for us, we think there are probably around 30,000 people still without coverage. We think more than half are probably eligible for Medicaid, and the others are probably eligible for full pay, with some smaller segment eligible for premium reductions, APTC. So going into this open enrollment, we are using strategies that worked really well last time around, the last two cycles, and we're doing new things. And I'll mention the things that we're doing that are new. We are launching, revamping our social and digital campaigns. And as some of you know, Julie knows, I'm not even on Twitter. So it really is amazing what good staff can do to utilize the latest technologies understanding what certain populations use. We know that Latino population pretty much uses texts as the main way to communicate, not email and not other ways. So the Greater Hispanic Chamber of Commerce, who is a partner of ours, they're going to be doing lots of texts to their members and people they work with. So we are deploying pretty sophisticated social media, digital media approaches to reach the die-hard-to-reach population. We've also been very successful at reaching younger folks. We have a very healthy and mixed risk pool. Our largest age category is 25 to 34-year-olds. And we want to make sure that we keep it very mixed and healthy, because if you only are providing coverage to older people, and none of us are in that category, of course, insurance gets more expensive. You really do need younger people to help support the risk pool. So we are trying to figure out what other creative strategies we can deploy to continue to attract 20-some-year-olds who, for some reason, are still not insured. The last several open enrollments, we've been very successful at very creative events like all-nighters at Ben's Chili Bowl, the diner. When I say we, I don't mean me, but some of my staff who are all-nighters participate in those enrollment events. If you ordered pizza on Super Bowl Sunday, you got a flyer from us saying, don't miss the deadline, get insurance. So we are thinking through what creative events we can launch this time around to get even more younger folks covered, and of course to reach the diehards. I don't know if I'm over my time. I can continue talking, or I can stop and take questions after everyone is done.
I think that's up to you and whether you feel like you have more to say. If you do, I would just,
thank you. I'll just close by saying, unlike California, they are an active purchaser. We're not. We took the approach of we're going to reorganize the private market, meaning we're going to set some rules in addition to the Affordable Care Act consumer protections that encourage competition without us negotiating. And that has worked really well for us. Now, we do participate in advocating for the lowest possible rates. We have Oliver Wyman, who does our actuarial analysis and provides that feedback to the insurance regulators. And we, of course, always advocate for our customers. But we let the market do its thing. And what we've discovered is carriers are getting smarter at the kinds of products they offer. And they're looking at the most popular products, and they are really innovating. So the Affordable Care Act lets you be successful taking either approach, either the active purchasing or the approach that we are taking, which is fair rules. We'll advocate for our customers, and we'll let the private market continue to innovate. Thank you.
Great. Peter?
I'm Peter Van Loon from Connecticut. And I took 7.5 years of Latin. And there's a word called munda, which is the world. And it's used now in the word that we use, mundane. And I use that word a lot because that's what we're focused on and what we have been focused on the last 2 years. Those things that are of the world and that are mundane, but if you don't take care of them, your customers are going to walk. The last 2 years in Connecticut, we've tried to keep things as simple as possible. We've been disciplined in our budgets and our deadlines. We all come from the private sector. There are a bunch of us running dog lackeys of the capitalist bourgeoisie on the staff. We've been focused on marketing, targeting, and we've had some success. We've cut our insured rate in half. We've engaged a quarter of the population of the state. But one of the things that's really cropped up is the customer service aspect. One of my biggest mistakes when I started was I thought customer education was a question of training people how to use the website. One of the biggest errors that we made. because that was just the start. We did find that the brokers needed a lot of help, from sometimes using the on-off switch on a computer to getting heavily into technology where they haven't been using for the most part. But the real focus that we found was on the individual customer, because that is where we've had the biggest challenge. The first year, a lot of basic questions right around the mundane. What is a deductible? Coinsurance. I used to get complaints saying, you're charging me a deductible and I've already paid my premium. You're double dipping and I'm going to call the governor now. So this is just, people aren't used to this. And I'm not saying these aren't necessarily folks that had been uninsured. These are folks that had never been engaged as an individual with their health care. And now they were learning. We started to adjust those first year, then second year, some basic education with our own outreach, working with the partnerships in the community, and it was different. When there's a lot of nice strategic thought about population health management, but the people that were calling us wanted help with how does a deductible relate to an out-of-pocket maximum, and what are those two things? So we kind of shifted, and we took a couple steps back, and we went after that mundane discipline of dealing with the individual customers at the level that they were at. And it's been successful. We're nowhere near done, because as we sign up new people, we still go with that basic information. But what's been fascinating to me is the growing sophistication of the individual customer. Now we're into our third year. And the customers are now coming back to us, and that they're not asking necessarily about what the deductible is. They're saying, I have diabetes, my wife has scoliosis. Tell me what the best plan is for me, given the fact that I live in Manchester, Connecticut, and I want a provider that is both quality-driven and inexpensive. Because they've gone and they've done a little bit of work on their own, and they find out if they go to a major university medical center downstate, they pay 3x, but if they go upstate to the one down the street, they pay X. And they're no longer being satisfied with the fact that the reason for that delta in price is because we're a major university and you should be happy to pay more for us. The individual consumers are getting a lot more sophisticated and a lot more caring about where they spend their dollars. A growing recognition of cost and quality on an individual basis. So as we look forward into Open Enrollment 3, we look that we have to maintain our focus on that mundane stuff. Our system needs to be able to be up and running and communicating with both our Medicaid agencies and our carriers. It is our integrated eligibility system, but that's not enough. We feel that our future and the future, I think, of healthcare is as a trusted advisor. And I say that we have people that are clamoring for help to understand this. And we've changed in Connecticut because we thought that what we did was build a technology and processes to help people determine their eligibility for Medicaid or insurance and purchase the same. And that was true. We did build that. But what we found that we've generated the most success and the most traffic back is the fact that we've done it in such a way that we've engaged the customer, that they look at us as a trusted advisor. And when I say that, across the board, from Medicaid up through the insured folks, and we think that's where the future is. And we've heard a lot of talk about various tools. we're not focused. We have a tool that we're developing, somewhat like Mila described, to be able to help people determine what their potential risks are. But what we find that those tools aren't really as effective unless you're sitting right there next to them and helping them comprehend that. And in Connecticut, that means that we have to have a renewed coordination with the brokers, because in Connecticut, if you're going to help somebody determine what insurance you're going to buy, you need to be a licensed broker. So we are continuing our collaboration with those folks. We're continuing the collaboration with the carriers, because as these people get more sophisticated, they want more and more information. And it's not just in general terms about what I can expect, but specifically, since I'm signed up with Carrier Y, what's it going to cost me to go to Manchester or to that major university downstate? Fascinating. And now we're starting to have people call up, and we're just seeing the anecdotes about this, is why is it so expensive even when I go to Manchester? The individuals are focusing on the absolute cost of healthcare now. I think it's fascinating. 15 years ago, I was in a startup in consumer-directed health, and we failed. And we had great technology, but we didn't engage the individual to the extent that the individual now is ready to be engaged. And as we go forward, we know that we have to keep our customer service up. We have to answer the telephones. We have to have seamless enablement of the individuals when they use our system. But that's not enough for our future success. For us to be successful, we need to continue as a trusted advisor and expand our ability to engage our customers as individuals with their individual situation. And some of it's going to be tools, but a lot of it's going to be feet on the streets and a continued focus on some of those mundane aspects of community outreach, engagement of the brokers, and ensuring that we leverage those people in the community that are focused on the health, not just of the populations, but of the individuals themselves.
Great. Well, you have a sense of what the leading edge of issues are for these folks, and it's now time to take your questions. You're an unruly crowd, so I figure we can manage this pretty easily. Please identify yourself and wait for a microphone so that we can capture your questions and comments. I don't see the microphone.
Okay, we'll go without the
We'll
microphone.
go without the microphone, but you can identify yourself and speak clearly, and that will do our best. Yes, go ahead.
Hi, I'm Sarah Hansard with Bloomberg BNA. Mila, you said the carriers were getting smarter and they're looking at the most popular products. Can you elaborate on what you're talking about there?
Yeah, so in our first year, we had one carrier that had over 100 products in the small group market, and realized that employees and small businesses were not attracted to many of the products, and it was just too complicated to make a decision, even if the small business wanted to be insured with that particular carrier. Too many products, and the differences among the products weren't significant enough. So in the second year, they lowered the number of products, and now for next year, it's even more decreased, which is positive. Because it will make it easier for customers that want to go with that particular carrier to be able to make a more informed decision. And we also found that even with the search engines, because there were so many products that you received as a result of your search as a customer, that people were not choosing that company even when the benefits were better. The price structure was better, the network was better. So that particular carrier learned a significant lesson from the experience. Also, our market is slightly different than the rest in that more than half of our small businesses choose Platinum. And the other big category of coverage is Gold. And so all carriers understood that right away. 3 of the 4 carriers on the group side actually are offering significant gold and platinum choices now as a result.
And how many enrollees do you have individual? I know, are most of your employees, your enrollees on the small group side? Or?
It's mixed. I was just looking at data from a couple of weeks ago. So close to 25,000 on the individual side have come through us. That includes dependents. Doesn't mean today they're still with us, but from day one, from October 1, close to 25,000. We have a single no wrong door policy, essentially. So people who come through DC HealthLink also get their Medicaid determination as well as APTC. And so over 120,000 have been determined eligible for Medicaid through DC HealthLink. And on the group side, over 21,000 have come through SHOP. That does include congressional enrollment.
And they're like 12 or 13,000 for congressional?
I don't have that breakdown. I can probably get it to you. But it is significant.
Yeah.
Dan Diamond with the Daily Briefing on Forbes. So this question's for Peter.
Oh, we do have a microphone. Go ahead.
Oh, thanks. So this question's for Peter and Mila, which is, if you're looking at the various state-based marketplaces that did well these past 2 years, what did they have in common? And the ones that didn't do so well, what do they share in common?
I'll take a first shot. I think the ones that did well had a disciplined approach of program management. And I said that deadlines and budgets. I also think that a recognition of customer service and the fact that you need to have the phone answered and take care of those customers. Not the first time. We learned that with customers, there's a lot of times where you only start the communication. You don't get stuff done the first time they call up. As far as issues, I think every exchange had significant issues. I mentioned the one that we fell down initially on the breadth of our education of our customers. It was a very intricate technology. And how people addressed it. There were different levels of improvements that need to be made. If you wanted to come to Connecticut, I could go for about 4 or 5 days about all the things that we did wrong and what we did to fix them. But that's what I know because I was the chief operating officer at the time, and I was culpable for all those things. I talked to my other states, and I find that we have very similar circumstances. So I'm hesitant to pass judgment on anybody except ourselves because I know that we had plenty of things that we did wrong, but we were able to fix a lot of them. Those things that we haven't fixed yet, we're trying to.
So we only had 9 months to get ourselves operational. I was the first hire, and I came in January 2013, and in October we had to be up and running. So we right shifted, which means everything that wasn't core we took off the table and just laser focus on what really mattered. A great team. The person I hired to lead my IT effort, she was in the district government under Mayor Williams, and it was during the Y2K. And so she took the district from ancient computers from last to first, really, in terms of being prepared. The team she assembled included private sector folks, AOL, other private sector folks, and folks who worked for government in the past, who understood the limitations and the challenges and the opportunities. So that made a huge difference. But the biggest thing for us was right shifting, and it was my job to say no to everything and take things off the table as we progressed. But October 1, we had a great October 1. One of 4 states to open on time stayed open all day long, and for most functionalities, people were able to go from start to finish. The one thing that we learned was that even though customers can go from start to finish, it was clunky. You know, it sometimes would take a while to load a web page, and all of us expect 2 seconds, and then we're done with a website if it doesn't load quickly enough. So most of our focus has been really paying attention to customer feedback. Even if one customer is saying this is bad, it matters to us. And so all of the upgrades that we've been focused on has been to respond to the fact that our customers are pretty demanding. They're sophisticated. They may not understand health insurance, but they understand online shopping. So that has been our focus to improve. We went from 20-some screens to 5. And we're making lots of deployments before November 1, actually. October is a busy month for us.
Sure.
Thank you. Julie Ravner from Kaiser Health News. Mila, is your checkbook tool the same as the one that they did for Illinois? And I know there was some discussion about them trying to do one for healthcare.gov. Do anybody have any idea what's going on with that?
So ours, of course, is the best. We've had them tweak some things, given our experience with our customers. I think it's the algorithms that they use to predict and give you a list of, best options to worst options is that well-tested technology. So that is all the same. But the look and the feel and the way information is presented, I think is better than the original Illinois approach. Checkbook also does a private exchange in California. And I do not know the status of their relationship with the federal government in terms of the marketplace.
When I was doing the story in Illinois, when they were talking about trying to get in to have some kind of decision tool for healthcare.gov.
I think at that point, Julie, they were using just the same tool they used for the federal FEHP program, and without the Mila kind of add-ons to it.
Oh, one other thing about consumer checkbook. One of the limitations is you can't put in what prescription medicine you need and have that be part of the analysis. We're working with them, and hopefully the goal is for next open enrollment next year to launch that feature. But that is it's going to be a heavy lift for them.
Amy Goldstein with the Washington Post. Joel, you mentioned that on balance, the pattern on the exchanges is higher cost sharing than has been the case in employer-based coverage. So from that, I'm wondering, as the other two of you talk about astute customer shopping, how much can astute shopping offset that pattern? In other words, is it getting into the third year, are plans participating in the exchanges differentiating themselves more? Are they converging on their benefits design? I mean, how much can being smart in choosing a plan compensate for this overall pattern of higher cost shifts?
If I may, I'm an old underwriter, and I don't think the plan design is kind of mirror what Mila said, is that people offer a lot of plans, but people self-select into a small few. The question is then what do they do once they have that? And I wonder if plans designs are the effective part, and more educating the consumer, since more and more of that is on their nickel, so to speak, to be it's not educating them. They're demanding to understand how it is they should spend their money. So I'd say that plan design is, you've seen the high deductibles and the increased out-of-pocket maximums track with trend. just as a way to cost shift to the individual and away from whoever's paying the premium. There's more to it than just that, but the idea is the customer needs to be engaged to understand, and they're demanding to be engaged is to understand about how they're spending their money. And they want transparency of costs. They, just like when they go online or when they go to the store, they want to know the quality and the cost of what they're buying. Wherein previously they had been either divorced from that, from the fact that their employers paid for it and they just paid a copay or what have you, or they had never been involved in it in the first place. So it's an interesting shift. I don't think it's going to change with plan design, though.
Can I just follow up for a second? Then? I mean, the premise of what the two of you are saying is that if people shop really well, they can find plans that are best for them. And what you're saying is that people have to be prudent about how they utilize care. And that's a different point. But in terms of the available plans, that's what I'm wondering.
So we, from day one, we prohibited benefit substitutions in the essential health benefits package. So we actually ended up with more standard type looking products than in a typical marketplace. We did allow supplemental benefits outside of the EHB, like acupuncture and whatever carriers wanted to offer, but we didn't have standard deductibles, copays, co-insurance, not true standardized packages. For next year, we will be having them for 2016. So this open enrollment will have some experience whether complete standard benefits and out-of-pocket costs yield better value for our shoppers. That combining with the consumer checkbook tool will make many customers more informed and more savvy about which health plan they should be in, and their risk tolerance. We're not going to have really good data about am I making the right decision for myself? For a while, we can survey our customers. Our response rate doing internet surveys is it's dismal. So they're not very. I can't say that 20% of the responders made the right choice. It's still a work in progress. But in the next couple of years, we'll understand how people make decisions and what else we need to do. I agree with Peter, the point that he made about individual help. With some of our customers, we know they will never be on the computer. They just won't. It's a particular culture preference, and with some, it's a generational preference. And so that individualized help is really critical, and we also rely on our brokers to do that, and our assisters and navigators to a lesser extent on which benefit package is best for the customer.
I just wanted.
Can I add a couple points to that? I mean, I think plan design isn't the panacea, but it is part of the picture. The most important part of it is what Peter said, which is it gets the customer price sensitive, and so choosing among different providers will be an important part of the future, I think, and the consumer will sort some of that out. It all won't be sorted out through networks. It'll be sorted out through consumers choosing. There'll be things like reference pricing that we already see to really focus on who's the most efficient provider and so forth. But the second part of it on plan design, I think, is it is going to get a bit more sophisticated. We're talking about value-based purchasing, value-based benefit design, where you really do try to go in there and say, if you want people who have certain conditions to take certain actions, then you ought to vary the cost sharing for them. Get rid of cost sharing, say, for a diabetic on certain things that you really definitely want them to do. So I think there are things within plan design, combined with good search tools, that will help people in that regime. And then the third thing I'd say is it is true that 100 different plans nobody's going to really sort out between 100 different plans. But one of the things that I think people take as a middle ground between standardization and let's let everybody have however many plans they want is let's make everybody pick 2 or 3 plans in each metal level and really get to. There is a difference between some people want this kind of deductible, other people want cost sharing, co-insurance instead of deductibles. There are differences in people's behaviors that I think will become part of the fabric here.
And both of you spoke generally a little earlier about new insurance plans, new designs that we may see coming out this year. Can you be more specific about specifically what kinds of new insurance products we might see in this open enrollment period?
Yeah, just quickly. So limited network plans have not been very popular in the district. In fact, we have mostly nationwide networks, so you can live in California and be in network. And the local networks are really regional, so we have Northern Virginia, parts of Pennsylvania, West Virginia, of course Maryland, and some parts of Delaware. So even the local networks are pretty broad. There are a couple of new products that are experimenting with more of the limited network structure. It remains to be seen whether there are buyers for that. Kaiser Permanente is in our market, both individual and small group, and unlike in many of their markets, they offer point of service in addition to their staff model, and that is one of the best sellers when you offer that kind of combination. So buyers demand the I guess, more options when it comes to networks, but that is a major new thing that we're seeing with some of the new products.
For our this open enrollment, just really tweaking, but what's really fascinating for us is the emergence of provider organizations taking risk and acting as their own insurers. And I think that in the future we'll start to see providers on the exchanges directly. But of course that requires a lot of the regulatory hoops to jump through, reserving requirements, what have you. But there's a definite desire for a lot of the providers to go direct, and we'll see that in the future.
Also, a number of you, I keep hearing brokers, and early on we were talking about navigators, assisters, and we're hearing a lot more about brokers. So what is the trend there, and are we going to be seeing a lot more of brokers?
It's gratifying for me because when I first started this, I think I was hung in effigy several times by when I talked to the brokers because they perceive that the exchanges were going to put them out of business. That's not the case at all. As we shift to the individual, we need those brokers with their expertise to engage the individual. So I think some of them, the ones that are very focused, are seeing the value of this. I think in Connecticut, there's some brokers that have more traditional group brokers. They've had a tough time transitioning to the individual. But we're also seeing a lot of wealth managers get their insurance licenses because they need to be able to articulate how healthcare fits into an individual's financial plans. And I'm not just saying the folks that we have that are non-APTC. This is across the board in all of our communities. It's fascinating to see that people see what an opportunity it is.
I would say nationally, the exchanges are very much more open to brokers today than they were initially for the reasons Peter said. A lot of people saw the exchanges as an alternative to the brokers. Today, they don't. They see the brokers as friends. But I do think there's a couple trends that are going to evolve over time here. One is high volume. You're going to have, in the individual market, you're going to have to be a high volume broker in order to make it. Usually that means you're going to have a web component to what you do. So I think the most creative brokers out there you're seeing are ones that kind of link up an individual assistance model with a web-based application model. And so a lot of the brokers are getting much more savvy about the technology and buying the technologies over time. And then I do think in the long run, this isn't real popular with the brokers, but in the long run, people like me going to always want to touch it, feel it, talk to somebody about it before they buy it. My kids aren't that way. My kids really do want to go on the web at 3 a.m. and buy it without anybody around. So there is a way in which I think the smart brokers are seeing that over time, the web piece of their business gets bigger, the individual contact part gets smaller. Not saying it's ever going to go away, but there will be more self-sufficiency on the web for the same reason that there is if you look at the web just generally as a generational thing.
So for us, brokers have always been part of the picture from day one. When we launched October 1, 2013, we not only opened a portal for small businesses and for individuals, but we actually had a separate portal for brokers. And it was one of the first working groups that we set up, and it was chaired by Janet Troutwine, who's the president of the National Association of Health Underwriters. And the brokers really designed what they needed. She and other brokers have described the situation to me this way. There's some brokers who love paper. They just love it, no matter how great the technology is. And there are others who are really savvy. And then there's kind of in the middle group who are willing to learn, but if it's too complicated and if they're not seeing immediate results, then they're going to turn away and do something else. For us, essentially about 20% of our certified brokers have most of the business. On the group side, 79% of our small businesses have a broker. And I couldn't get the data on the individual side, but it's pretty significant. Early on, we matched up. We did matchmaking. We actually did get-togethers for brokers and navigators and assisters. And we focused on training the assisters and navigators on APTC, on eligibility, on how to get a person enrolled, and encourage them to partner with brokers to help make the plan selection. And that actually worked really well for us. This open enrollment, we're going to have some selected brokers as our enrollment storefronts. And some of the brokers who are pretty active with us tell us that they use it as an opportunity to be all service, auto insurance, life insurance, everything else. So even though they may not be seeing the same level of commissions that they used to see, they actually see the ACA and DC HealthLink as an opportunity to increase their business in all of the lines that they deal in.
Hi, Carl Eisenhower from Real Clear Health. My question is, between year one and year two, did you see consumers who purchase in year one come back and shop again? Or is there sort of an inertia once they've signed up for something, they're staying forever, and all these refinements you're making to help people shop more wisely is going to be, those people are going to miss out?
Go ahead.
In Connecticut, we had a capability to auto-enroll, where what happened is that those folks that we throw into batches, get in people revalidated, determine their eligibility for APTC. We'd look at the plans that were the closest to what we had, and all above board, we tell them what we're doing so they could give them an opportunity if they wanted to go in and shop. But 60–70% were happy to have the auto renewal happen, and we're seeing that percentage creep up. And most of the folks that did get back on and choose, they either had a major change in their financial circumstance that required them to get on. So what we're seeing is there's a definite desire to have the auto renewal work, but we also recognize that we have to educate people about that's going on so that they have the opportunity to shop if they choose.
We were in the first year. We took the agnostic approach. If you wanted to shop, please do. If you were happy with what you had, you didn't have to do anything. So we passively renewed people, what Peter calls auto renewal. Less than 5%, and I can get you the exact data, I just don't have it at my fingertips, less than 5% actually made an active change, meaning changed metal levels, changed carriers, or a different plan in the same metal level. So we're trying to figure out what we can do better. And you may have heard Aetna decided not to be in the individual business in DC anymore. They're on the group side, but they have about 500 people in DC who are affected because they will no longer offer policies on the individual side. So what we're doing with that population is a lot of reach out, not only by email and regular mail, but calls. And those are going to be our active purchasers. They're going to be active shoppers because they'll need to make a selection. So we'll know a whole lot what kind of support people need to be more active. So I call it really a pilot to see what lessons we can learn when people actually have to be actively engaged and make a decision. So we'll know a whole lot after this open enrollment with the former Aetna population. This year, we will be encouraging people to look for better deals. Some of the products, although on average we've had really good experience with premiums being leveled and just slight increases. For some products, the increases are significant, and a person will be better off going online and shopping for a better deal. So we'll be encouraging that as well.
I mean, auto renewal, I think, will be an increasingly important part of the marketplace as people get comfortable with their products. And like all insurance markets, it's a sign of a mature market that most people want to stay where they are. They've made good choices. But I think two things will make this market unique. It already is unique in the number of people who actively renew. One is, as long as prices jump around and the subsidies are tied to price, you're going to have people wanting to price shop, or that you should be encouraging people to price shop. If that's true. And then the second thing is, the one thing that hasn't changed in the individual market is that it's a relatively transient market. About a third of that market, at least every year, moves into employer-based coverage or into Medicare and Medicaid. So you're always going to have this phenomenon, which makes it very difficult, that probably a third of your customers, even if you're doing everything right, leave you every year. You have to add another new third of people coming out, that are in transition between two major employers or something. So there's just going to be a lot more focus on active renewal tactics in this market, but still you should not lose sight of the fact that the majority of people in this kind of market are going to auto renew.
In Connecticut and D.C., do you have any idea if people have financial help adjusted after reconciliation of APTCs with actual tax credit?
So we're going through that now. The IRS has not provided us with a list of folks, so we actually have to reping the federal hub to get information on non-filers, and that is happening in October, essentially. If you want to follow up with me in November, I'll have a better sense of how many people did not file. We estimate very few. We only have about 10% of our individual enrollees receiving APTC. 90% are full pay. So we don't anticipate too many people losing their APTC because they didn't file. Usually there are adjustments to APTC, and of course when the second lowest silver plan changes, that makes a difference as well. So we expect to see some differences going into 2016.
Did your second lowest silver plan change?
I think it's still a Kaiser plan, but the costs changed slightly.
We, after this past tax season, we've got anecdotal people calling up and reconciling what they had. It was mostly driven by the fact that folks were getting comfortable with the whole 1095 process and how the taxes work. We're like Mila, in the exact same boat. We haven't gotten any information yet from the IRS through the Federal Data Services Hub as to understand how many folks have failed to reconcile. We're trying to address that with communication. Of course, it's federal tax information, so we can't target individuals. We have to handle it more on a broad education perspective. But we found that there's an opportunity, there'll be an opportunity to educate individuals about the tax implications, especially if they haven't filed their taxes in the past year. And they have our number and they do call.
I just want to underscore, in this area, the IRS is just not helpful. With the first, if they're listening, I'll be audited. That's fine. Everything is still new. It doesn't matter that the ACA has been law since 2010. It's just still new. And some people still don't know that they're going to be subject to a tax penalty if they don't have health coverage. And so this year especially, I felt like there was a good public policy case to be made to the IRS. Just give us the list of non-filers so we can do outreach to them and encourage them to file their taxes late so they don't lose their financial help and potentially their health insurance. And the IRS is taking a very strong posture on this, and they're not giving us the list. So we have to wait until we actually ping the federal hub to get, red flag on a non-filer.
I have a question for Joel. Steve Davis with AIS. On the risk corridors and the low reimbursement that was announced last week, how does that impact state regulators? Are they going to have to, do state regulators have to scramble now to look at the solvency of some of the smaller carriers that might be impacted by the corridors?
Yes, the more established carriers, of course, have deeper reserves, and so they're probably not an issue on the solvency side. But unfortunately, some of the new entrants, either on the co-op side, maybe some Medicaid MCOs, other kinds of new entrants that have thinner balance sheets, yes, the state regulators will have to take another look at that, and I'm sure we'll have some questions for the federal government on the future of the risk corridor program.
I'm glad that we started talking about the IRS, although it kind of stole my thunder. Is there anything else that I can just be loud. Is there anything else that you guys would like to see out of HHS or the Treasury or Labor to, I guess, make your lives easier this open enrollment? Anything you're still waiting to hear on from them?
Should I start? Thank you so much. What's your name?
Policy.
Great. I'll say this: HHS and CMS are undergoing through the same. They're going through the same growing pains, running a federal marketplace, understanding that their own regs sometimes are a challenge to implement. So they're kind of in the same boat as we are. The IRS has not shown evidence that they recognize some of the challenges that we face. And so a lot of times on the reports that we have to do to them monthly, they give us specs very late, and we can't build it into our reporting structure because, we have a roadmap for IT, and even though we're pretty nimble and we're becoming more nimble, it takes time to build that in. So they haven't shown the flexibility that I would have liked them to show. And they're very late with their specs. And the example I gave earlier in terms of just not recognizing that the ACA is new and they can actually be helpful to the states and help people stay insured. That has not happened. Also, and this is not their fault, but I don't think they have the kind of resources they need to actually handle consumer calls. We also get consumers calling us, and we cannot give tax advice, tax information, nothing. So we're in a very bad place. We want to be helpful, but we're limited in what we can do. The one thing that we did last year that really made a difference for our customers, we not only sent the 95As by mail as required, but we made PDF copies available online. And through a bunch of audits and reconciliations with the carriers, our error rate in correct information on the 1095As was very small. And a customer, like on April 15th or whenever the deadline was last year, within an hour we can get the 1095A fixed for them and upload it so they can use it. So that worked really well as a customer service for our customers. I don't know how many people really understood what to do with that information. discretion, though, as in their taxes, and really the IRS is in the best position to educate people about that, and they haven't done that.
Just to point out one specific there that I think Mila's shop did a really good job on, kind of goes to Peter's point about the mundane and attending to it. They made those PDFs available just with your name and social security number, so you didn't have to remember your password and all the other things to get into your whole account. You could just quickly access it. We did a work group around this, and a lot of states are now adopting that particular reform. It's just an example of a simple thing that can be done to make things easier. The tax preparers are also a big help in this area because they do know what to do with those PDFs and how to download them into people's accounts. And one of the consequences of the ACA is that more people now have to go somewhere to get help with their taxes. And so states doing things to line up with the tax preparers, I know Connecticut's done some of that too, has been important.
What Mila brought up, I agree with. And it is a continuing opportunity because we in the states and the district, we don't have the luxury of waiting till we have 100% valid direction from anybody here inside the Beltway. The deadlines pass and our customers need to get served. So we've always had a healthy tension with acting on less than 100% of the information, but that's what good customer service is about.
So before we wrap up, first, again, I want to remind you, please fill out the evaluation form in your packet to let us know. Again, we're partnering with the Alliance for Health Reform, Health Affairs, and the JKTG Foundation. And we really want to, we're going to be doing more of these breakfasts, and we really want to hear from you about what you want to hear about and who you'd like to hear from. But before we wrap up, I'd like to ask Joel and also Mila and Peter if they want to weigh in. You talked about some general trends regarding premiums and other cost sharing, deductibles and such. What can you tell us specifically about what we have so far? We're less than a month from the open enrollment. Are we seeing some states that are much higher than they were last year, some states any lower, about the same? I mean, what can you tell us concretely that you know at this point?
Again, it's all healthcare is local, so it is very hard to generalize. Even say within the state of California, where they have a generally 4%, it's much lower in the LA area than it is in Northern California, and that has to do with provider networks and so forth. So it is very hard to generalize, but I would say my strong impression, without being able to give you all the analytics, is that things are compressing. They're more stable now than they were last year, and I expect them to continue to get more stable over time, if only because the whole theory here is that where it used to be these very small little rating pools, now it's a big rating pool on the individual side, just like on the employer side. And when you have that, the whole pool moves more slowly and it's more stable. So I think the general drift here is more stability, but there is enough shift this year that I do think a lot of people, it's going to be very important to kind of emphasize price shop again, around your subsidy.
Concur. We in Connecticut, we haven't seen decreases, but we haven't seen anything near the double digits that we've seen in the past.
Yeah, and I just want to say, we've been fortunate that the actuaries that we use make a huge difference in terms of the analysis that they provide to the insurance regulators. But even a 1% increase, although it's not as traumatic as 70% or 80% that we used to see pre-ACA, that 1% could mean the difference between staying insured and not staying insured for some. So I don't want anyone to lose sight of that every premium increase matters. But the ACA has definitely helped to stabilize those.
Great. So thank you for starting your day early with us. We realize it's a Monday morning, and we had you here at 8:30, so we appreciate it. And we look forward to seeing you at the next briefing.